Well, thank you very much. It's an honor and a big pleasure to be with you here in person today. And thanks for the invitation. So, the journal, I have no disclosures. The journal is going into its 5th year, but it's still a young journal. And allow me briefly to introduce it in a couple of slides to you for those who are not familiar with it. The main aim of our journal is to connect the clinic to digital technology. You see it, AI-generated picture, of course. The 5th year we are starting, and soon you will also see that we have 11 chapters in the new textbook coming up. So digital health is now being more embedded into the backbone of the European society, and I'm sure also in the other societies around the globe as well. So we've also brought a lot of new keywords to the journal family and also to the Congress organizations. You have to show them in a word cloud these days, more modern, but you will see that there are keywords like the digital twin, in silico trials, virtual reality, augmented reality, precision medicine, clinical decision support, etc., which are all new, and it's great to have them and see them coming into the journal family as well. So what are we expecting from digital health and cardiology? Well, enhanced diagnostic accuracy, a better monitoring of the patients, access to more data for research, increase efficiency and cost effectiveness, and improve also patient engagement. And of course, the current main topics are AI, machine and deep learning, and I think that roughly 70% of the submissions we receive today has an AI component in it. Telehealth remote monitoring is a good second one, mobile apps, social media, patient engagement and personalized health, and electronic medical records, precision medicine and clinical decision support. That are the main topics we receive. So we are an open access journal, so every one of you can read all the papers we publish. And we are very pleased that we have a global reach. If you look to the figure at the bottom right, you can see that we have almost an evenly divided readership between the US, Europe, and Asia. And this year we received our first impact factor, which is 3.9, which is a very respectable one, and it brought us directly into the top quartile of the cardiovascular field. We always have, since a couple of years, a best-of digital health session at the European Cardiology Congress. This is a picture of 2 years ago, but the audience is full, and this year it was almost the same, so there's a lot of attention and it's really growing. Back in the day, I was also a chair of the working group of computing in cardiology, and we had 2 sessions. These years, if you look throughout the Cardiology Congress, we had 50 sessions where digital is a part of it. So what I also did to select of the best papers, we have 4 presentations we had during that session, is also used the number of downloads, the citations, but also the altmetric score, because a citation scored paper that needs some time to mature, so that will evolve roughly over 1 or 2 years. With altmetric score, social media and news outlets that give you direct feedback how well it is appreciated also by the larger public. This paper is a deep learning model for strain measurements. And strain measurements are not so easy to perform by hand or manually, and it would be great if you could serve some time to do all that analysis by yourself, by manual. And these authors developed a model that was tested in 3 cohorts, patients with and without heart failure. It was compared to core lab standard echoes from patients with HFpEF and also patients with suspected acute myocardial infarctions. And the algorithm was outperforming those of manual and core lab performed analysis. So that could really speed up, and we are very pleased that we see more and more artificial intelligence methods being applied to cardiovascular imaging. So we pick up also a little bit to the field of the radiologists who are far ahead with their AI developments. This is another one, AI to detect coronary occlusions by only a 12-lead EKG by Robert Herman. It's a very attractive paper. It was for many months the top read paper in our journal. And whenever Herman is presenting, all the interventionalists are attacking him because they used the 12 lead to directly identify an acute occluded coronary artery, and it outperforms the STEMI criteria. They validated it on an international data set from both the US and also in Europe. So it is external validation, which is very important to evaluate the models of AI, to do that, to have an external validation as well. And they're running quite a large number of registries to further validate and also to get this to the clinical side. And you can even participate in that if you are willing to. You can find that on their website. It's called Queens of Heart. Take a look. This paper evaluated if premature atrial and ventricular contractions detected by a wearable device, a lifestyle device, could identify patients at risk for heart failure or atrial fibrillation. And here they used, as Professor Guzik also showed one example, data from the UK Biobank. I will come back to data banks later on. And the authors found that indeed the wearables could detect those premature beats and also identified patients identified in the biobank later on developing heart failure or atrial fibrillation. So wearables could perhaps change from lifestyle equipment to medical grade in the near future, hopefully. This is a paper by Professor Jagmeet Singh, a well-known and well-respected electrophysiologist from the United States. He has written a very nice book during COVID about artificial intelligence. And what they did here is what we see also in a lot of other submissions we receive, I think the most, to use AI to detect atrial fibrillation. That's not so strange because the Holter tapes and Holter recordings, that is the largest database we have in cardiology. So what they did here is that in patients who doesn't show atrial fibrillation in the first 24 hours, to see if the model can detect if they later on, after the 24 hours, are at risk to develop atrial fibrillations. And they tested that in patients who had a Holter monitor for 7 or 15 days. And they could identify that in a test set of almost 10,000 patients, that in 360 patients, they could identify that they were at risk for getting atrial fibrillation later, which they could detect on those longer Holter monitors. So it suggests that if you have a patient, use the model, that you can earlier decide, oh, these patients need a longer recording and not sent away without. So this is a list of the top-cited papers we had, papers which are a little bit also more mature. The top one is from Harriet van Spal, and that has already received more than 100, but in the last year it was over 40. It's about barriers and facilitators of the implementation of digital health technology. I will come back to this paper later on. From David Plants, we had when to go to bed on a time with the lowest risk of developing cardiovascular disease, also using the UK Biobank study. And that has the highest altmetric score we ever had, almost 3,000. From Magnus Jensen, he was the chief of the working group of e-cardiology. They also looked to wearables and to see if they can be helpful in tracking primary and secondary prevention. Sarah Friedrich has written a great review paper about applications of AI in cardiovascular medicine, a review with recommendations. Behar had AF again, with biomarkers and deep representation learning. And Francisco Lopez Jimenez is from the group of the Mayo Clinic from Professor Paul Friedman, using the 12-lead EKG electrocardiogram as a biomarker of biological age. It's also a very popular topic. You also see it for the brain of the pancreas or other organs these days, to use AI to do that. But we are also very pleased to see a lot of contributions from China in the journal. These are before 2024, and you are picking up steam, I must say. This, what we have, or what we could publish already this year, and I do know that there are a lot in the pipeline also. So to take a few, this was the most popular one, not so long ago, about developing hypertension related to the use of mobile phones. It's not that the causality is detected here, but also UK Biobank data. So be careful about using the mobile phone too much because you could get some hypertension later on. Risk prediction and electronic health records are a very popular area as well. And we see also a lot of developments here. And it has also been related to implementation of the guidelines into your electronic health record for clinical decision support. I think the app we saw this morning is also in that kind of direction. And you could see it outperforms that what you do manually, and it could hopefully being implemented later in the future. But it will be a problematic in Europe because in every hospital we have almost a different electronic health record system, and to implement it, that will be a real challenge. Another popular theme, and I know that there is one expert here on the front row about it, auscultation, a little bit a lost art since we transferred to echocardiography, but it's now making a complete revival using electronic and digitization, AI, to detect possible adverse effects in the patients. It was with a digital stethoscope in almost 1,400 patients. And the AI outperforms that or close matches what the experts would do. Personally, I like this one very nice. A gait video analysis, you see that almost a little bit growing. Patients has to stay home longer and longer. So if a camera can already detect early diseases, they use it for Alzheimer, Parkinson's disease, but also for cardiovascular disease. So it's surprisingly that shows up in a video analysis, but we will see probably much more of this in the near futures. There's some topical articles what we receive are of course ChatGPT. ChatGPT can be commended for making AI democratized, and now we have a whole lot of different AI models, Copilot, Claude, Perplexity, Gemini, etc. And you see it on the news almost daily. Also very attractive sessions on the annual congresses as well. And this short paper steered a lot of discussion within the journal. We received it a year ago, and the authors used ChatGPT to do the European exam in core cardiology. And they were able to show that the ChatGPT was able to make that core exam besides images. But recently we already had new ChatGPT versions which can also interpret the images. So I'm sure that such kind of papers will come up again. But you see that it received already 65 citations, and that for a short report, that is very remarkable. Also, the letter to the editor inbox was also filled with all kinds of comments after publication of this. And this is the paper of Harriet van Spal, of which I was speaking about earlier. One of the problematic issues we have is to implement digital health later on into the clinic. We see a lot of early developments, a lot of pilot studies, but to get it back to the bedside, that is sometimes difficult. In Europe, we have the AI Act. I don't know how it is here in China, but the regulations are very strict. Software is a medical device these days, so you have to do a lot of regulations. You have to do a lot of evaluations before you are allowed to use it clinically. And that is the biggest hurdle we have. This is, by the way, one of the best graphical abstracts we had over the time, really identifying and put the finger to the pain what we have to get things into the clinic. So other possible articles for you could be, if you are new to AI, is to read this point of view in the teaching series of us, to give you a little bit the background in the basics of artificial intelligence. You can find that in the journal. And one important thing, Professor Kusic was touching it, open science. We all know that AI is data hungry, so we need data and a lot of data. What you don't see in AI developments is power calculations anymore. Sometimes you see studies with 100 or 200 patients, sometimes with 1,000 or 2,000. some with 10,000. But if you go to the people of the Mayo Clinic, who were the pioneers of developing the AI algorithms for EKG, they use 500,000 EKGs, and perhaps you need even 1 million. So what we need is big databases of good quality, who are good described, and for that we need to team up. So what we introduce now, as the first in the journal family, is a new format, data papers. And Sandy Engelhardt has written a very nice editorial about it, why we need it. So if you, and in China you have enormous amounts of data, are willing to make your data publicly available, of course according to patient privacy and informed consent and things like that, please write a paper about it, where we can find it. There are several cloud services in which you can store your data, which can be used, which are secure. And that is the way we must go forward, to have open science, but also open data. And it's really crucial. So I think that was, oh yeah. And why should you publish in EAA Digital Health? Of course, is it open access, visible worldwide. We have good quality peer review, although sometimes difficult to find the AI experts, as Professor Crea said, because you want to have people who know the pathology, but also know the data science. But probably you need some mix and have more interaction. We have a simple submission system. You don't have to format it in directly what we need. If you is rejected somewhere else, you can just send it by yourself. And I think we have an excellent reputation so far. So thank you very much.